Okay, let's jump right into this explainer. If you're looking to completely master the maternal newborn module and absolutely crush those tricky exam traps, you are in the right place. Today, we're zeroing in on prenatal care and fetal well-being. Why? Well, because these areas are absolute gold mines for test writers. They love to test your ability to prioritize safety above everything else. So let's get focused and break these concepts down.
Picture this. You're out on the floor, the pressure is on, and you're faced with this exact clinical scenario. A client at 36 weeks reports decreased fetal movement. What is your immediate, absolute priority action? Do you check her blood pressure, ask her to recount her diet for the day, or do you immediately hook her up to a fetal monitor? Pause and think about what truly matters most in this very second. Now, here's the classic NCLEX trap. The exam is literally begging you to choose a comfortable, passive action, like checking maternal vitals or just documenting what the patient said. It feels like good nursing, right? But wait. A lack of movement strongly implies fetal distress. In that scenario, assessing the fetal heart rate is your #1 priority, no question. You have to establish fetal well-being right then and there. All right, moving right along to Section 1, prenatal assessments and labs. Look, it is so incredibly easy to get totally overwhelmed by the massive laundry list of blood work ordered during that initial prenatal visit. So we're going to use a chunking technique to save your memory. First up is the maternal baseline chunk. These are your foundational blood and genetic screens. We're talking blood type and Rh factor, super critical so we can prepare for irregular antibodies early on. We also pull a CBC with differential looking at hemoglobin and hematocrit, run an HGB electrophoresis, check the MSFP, and of course schedule those 1-hour and 3-hour glucose tolerance tests. Okay, next up, we're grouping all the infection screenings into one big chunk. Identifying transmissible risks early is a massive priority because it's all about protecting the newborn. This chunk includes your rubella titer, Hep B screen, a urinalysis, PPD for tuberculosis, VDRL for venereal disease, and your HIV and torch screening. Here's the takeaway. When you see an infection question on the exam, your priority radar should immediately flash to preventing transmission to the baby.
Let's transition over to Section 2, Pregnancy Nutrition Safety Alerts.
So what you teach your client to put into her body, and honestly what you explicitly tell her to keep out of it, is a highly tested safety priority. You have to pay attention to absolute contraindications. Substances like alcohol are non-negotiable danger signs. You must identify them immediately. There is absolutely no safe amount of alcohol during pregnancy, period. As a nurse, you're actively assessing for these behaviors through health histories and journaling so you can jump in with immediate life-saving education. Sure, telling a client to eat plenty of protein, iron, and folic acid is great, but the test writers, they want to know if you can spot the red flags. You have to teach clients to avoid certain fish, like swordfish and shark, as well as unpasteurized dairy, soft cheeses, deli meats, and raw sprouts. These carry severe risks. So if an exam question offers a turkey deli meat sandwich as a healthy snack choice, you know instantly that's a trap. Now for the really high-yield stuff. Section 3, Assessing Fetal Well-Being. This is where things get really interesting because we're leveraging technology to see exactly how our baby is handling the uterine environment. We're talking about the biophysical profile, or BPP. Think of this as the ultimate report card for a baby in utero. It's an amazing tool because it combines real-time ultrasound imaging with fetal heart rate monitoring, giving us a really comprehensive, definitive picture of fetal safety. You've absolutely got to memorize these 5 components of the BPP. And here's the trick. It's a strict binary system. Each component gets either a 2 for normal or a 0 for abnormal. There are no 1s. We want a reactive fetal heart rate, breathing movements lasting at least 30 seconds, at least 3 gross body movements, good fetal tone showing extension and flexion, and an amniotic fluid pocket of at least 2 centimeters. Meet the criteria, they get a 2. Miss it, they get a 0. So what do these scores actually mean for you on the floor? An 8 to 10? Awesome, the baby is safe. It's a normal finding with a low risk of chronic fetal asphyxia. A 4 to 6? That's abnormal, and we begin to suspect asphyxia. But anything less than a 4? That is a blaring, high-priority safety alert for severe asphyxia. If you see a score of 2 on an exam, you better be preparing for immediate life-saving interventions. Okay, let's talk about fetal heart rate strips. These notoriously confuse students, specifically the non-stress test and the contraction stress test. But they are vital. We use them to figure out if the baby's central nervous system is intact or if they're suffering from decreased movement or intrauterine growth restriction.
Here is a memory trick to keep them straight forever. A reactive NST is radical and good. It means the central nervous system is intact and the baby is thriving. We love a reactive NST. But a positive CST, that is highly dangerous. It means the baby cannot tolerate labor contractions. The word positive here means we are positively seeing dangerous late decelerations. So remember, reactive is good, positive is bad.
Moving on to Section 4, high-risk fetal procedures.
Ultrasounds are great because they're non-invasive, right? But sometimes we have to perform higher-risk procedures to assess lung maturity or diagnose genetic defects. Take an amniocentesis. Because you are inserting a needle directly into the uterine cavity, your priority as a nurse is to fiercely monitor for life-threatening complications. You are watching like a hawk for hemorrhage, infection, fluid leakage, amniotic fluid emboli, inadvertent damage to the fetus, or the sudden onset of premature labor. Safety monitoring here is everything.
So pause and think about this for a second. Based on the safety framework we've built, how do you prevent preterm labor or a fatal infection in this exact moment? If your client reports sudden fluid leakage right after an amniocentesis, your immediate priority is to assess fetal heart tones. You have to ensure the baby isn't in sudden distress. After that, you evaluate the fluid and maternal vitals to intercept a potential hemorrhage or infection.
And finally, Section 5, Rapid Fire NCLEX Recap.
Okay, let's tie this whole explainer together with a high-energy recap. You've got the concepts down, now let's lock in these memory anchors so they are instantly accessible on exam day. Number 1, watch out for those nutrition traps. Absolutely zero unpasteurized dairy, raw sprouts, or swordfish. Number 2, a BPP score below 4 is a siren for immediate intervention due to fetal asphyxia. And number 3, our strip trick. A reactive NST is good, a positive CST is extremely bad. To wrap things up, let's think about the future. As maternal-fetal technology evolves from 2D to 4D Dopplers, will continuous, non-invasive monitoring eventually eliminate these NCLEX traps altogether? It's pretty incredible to consider how our diagnostic capabilities are advancing. For now, keep prioritizing safety in your practice, rely on the strong foundation you've built today, and ask yourself how evolving technology might change the way we rescue patients in the years to come.